Welcome to Studying for FRCS. This is Sai from the Mindful Learner, and today we're going to talk about management of constipation. Constipation might be a surgical problem, but actually it can be a surgical problem, although we're mostly managing it medically. And it's a very favorite topic, especially pelvic floor dysfunction. So let's to define what is constipation. Constipation is typically defined as bowel movements occurring less than 3 times a week, which is regarded as constipation. However, each person's bowel movement might be different. Also consider in special cases, such as in elderly, where there is non-specific symptoms such as confusion, delirium, functional decline, nausea or loss of appetite, overflow diarrhea, urinary retention. Underlying cause may be constipation. Also, if there is fecal loading or impaction, if there is history of hard lumpy stool, which may be larger or infrequent, for an example, passed every week, or a small stool but passes every 2 or 3 days, and also having to use manual methods and sometimes can even present as overflow fecal incontinence. Now, obstructed defecation disorder is another favorite in the vivas, and it is defined as the diagnosis of constipation which requires 2 or more of the following symptoms consistently for 90 days. That is, straining on more than 25% of the bowel movement, feeling that you did not completely empty your bowels on more than 25% of the occasion, hard stool on more than 25% of the bowel movements, needing to use your fingers to help pass stool more than 25% of the time, and fewer than 3 bowel movements a week. Now, what are the causes of constipation? If it's just the cause of constipation, then there can be multiple. And mostly there is low physical activity, changes in the routine. If you're traveling a lot, then they have a lot of history of constipation because unfamiliar surrounding, low fiber, low water intake, IBS, pain, laxative abuse, they are the common causes. Pregnancy can also cause constipation. Obstructive defecation disorder is a different thing, and this is usually caused by 2 factors basically. One is a mechanical cause, which includes perineal hernias, pelvic organ prolapse such as rectal prolapse, intussusception, rectocele, solitary rectal ulcer syndrome, and functional causes of it include anismus, which is a definition that's asked in the exam. So it's an inability to relax sphincter muscle and or push adequately to evacuate bowels. So the patient will be unable to relax the sphincter muscles and with also will be unable to push the bowel adequately to evacuate bowels basically. Rectal hyposensitivity is the loss of sensation into the rectum, possibly due to nerve damage, and it can be seen in women who has prolonged childbirth after, as it might stretch, and also patients who has chronic constipation due to straining can also have nerve damage. Psychological disorders such as anxiety, depression, phobias, OCD, and eating disorder can also associated with ODS. Now, going back to constipation, why, as I mentioned before, so poor diet, not enough water, lack of exercise, also poor toilet habits, and all of them needs to be kept in mind. And also you have to exclude other causes such as thyroid use, any medication, especially opioid, and also you must exclude any neurological conditions and of course any underlying malignancy. Now, how do you assess patients with constipation? So with any patient you assess with constipation, the main thing is you have to exclude red flag symptoms. So that means change of bowel habit, weight loss, bleeding, new onset of bleeding, feeling of tenesmus, that is urgency, incontinence, which is a new onset. All of these can be with, signs of a malignancy. So also define what the person means by constipation and what is their normal pattern of defecation. Duration, the frequency of the consistency of the stool, and from there you will be asked to refer to the Bristol stool chart. So usually type 1 to 3 are consistent. 1 to 2 actually mostly are consistent with hard constipation. Type 3 to 4 are actually considered normal. Type 5 can be also considered normal, but it lacks fiber, and 6 and 7 are with diarrhea. Whether the patient, what kind of problem does the patient having? Is the patient straining? Is the patient having rectal discomfort? Is there incomplete evacuation? Is there incontinence? And does the patient have to do anything like, manually digitate or use something to manually extract the stool itself? That is also important. Keep in mind, this is quite a sensitive topic, and some patients don't, doesn't feel very comfortable talking about this. So it is, as clinicians, our duty to try to find the cost to assess the patient. And then, of course, clinically, we need to examine with an abdominal examination and also a digital rectal examination. On the digital rectal examination, we must mention whether this patient has any, what's the anal tone like? Is there fissure, hemorrhoids? Is there any sign of incontinence? Is there any straining sign? And when you put your finger in, can you feel any mass? And also, can you see any prolapse when you put your proctoscopy in? These are the things that we must mention as part of the assessment. So another top tip, any patient with any kind of pelvic floor function, especially female patient, do not forget to ask about their obstetric history and any patient with the past surgical history in the anorectum. That is very important. Also, keep in mind trauma and abuse can also cause trauma that can cause constipation. So that also need to be kept in mind. So how do we then proceed with investigation? So investigation wise, first of all, you need to have a visualization. Now that can be in the effect of colonoscopy or in the effect of flexisigmoidoscopy, depending on the age. If it's a young patient, then at least you need to do a flexisigi to rule out any obvious pathology. If it's an elderly patient with some, maybe history of red flag symptoms, then you do need to do a colonoscopy. But some sort of scopy needs to be done. Now next comes the anorectal manometry. Now, this includes the anorectal manometry test, where we have to squeeze, where we ask the patient to have the squeezing and the resting tone of the muscles, and also what is the, basically to assess the patient's internal and external sphincter. Balloon expulsion test is another test we have to do. And if the patient has long-term history of constipation, then colonic marker studies, such as to exclude slow transit constipation, needs to be done. And this is important. If it's a female patient, and also if there's any history of any obstetric deliveries or any female patient, for an example, and frankly speaking, even in men, we sometimes do also endoanal ultrasound. If the patient has history of chronic straining and you think there might be a rectal intussusception or any other pathology, then a defecating proctogram is required. And if you're suspecting slow transit bowel, then you also need to do an x-ray. So the x-rays are that you give them markers for up to day 6, and on day 7 you do a plain abdominal x-ray. If there are more than 20% of the markers retention, then it is considered to be a slow transit constipation. And also if this is also calculated by a method called Aron's method. So just to keep in mind. Now, there is actually a definition of constipation, which is like the Rome 4 criteria, which has divided it into 4 segments. So 4 segments are known as functional constipation. So functional constipation is also known as chronic idiopathic constipation, which does not have a physical or a physiological, such as a hormone or a body chemistry element, but it might be neurological, psychological, or psychosomatic. A person with functional constipation may be healthy, yet will have difficulty in defecating. Then there is irritable bowel syndrome with constipation. And that is a common disorder which affects the stomach and the intestines. It includes cramping, abdominal pain, bloating, gas, diarrhea, and constipation, sometimes both. And IBS-C is constipation, IBS-D is diarrhea. Opioid-induced constipation is actually seen in 40 to 80% of patients who take opioids, and it's a very common thing to see in patients who has history of, especially any patients in a palliative setting, they actually suffer with it a lot. Functional defecation disorder, such as inadequate defecatory propulsion or dyssynergic defecation, which is also known as anismus, is another cause. Now, treatment. So, treatment is important, and the main treatment is always non-operative first. And the non-operative management is more dietary fibers with the goal of 30 to 40 grams per day, more water intake for more than 2 liters per day. Stool softeners such as laxatives, home enemas, and colonic irrigation can be used. And also physical exercise. Now, in some cases, yoga, and in some in some settings, even something like tree bathing or forest bathing, which is actually just a relaxation technique. So it's to improve your stressing life. That needs to be improved. Or any kind of physical activity is considered to improve your the improvement of constipation. The other thing that we don't often tell patients is how to correctly open your bowel, so how to correctly position yourself. Now, obviously, we were meant to squat in traditional times. We don't do that. We sit now on our English commodes and open our bowels. So the position is important. That is, we ask the patients always to use a step, and the knees has to be higher than the hips. Patient needs to lean forward and put elbows on their knees, and is basically just try to bulge out the abdomen, basically, and also try to massage it but straightening your spine. So that is actually a correct position to open your bowels, and that's important because that straightens your rectum to allow it to open your bowels. And this is something all patients we have to counsel. The second thing is, of course, we have to use laxatives. Now, this is another favorite topic, and this is something we need to know. So the laxatives are divided into bulk forming, osmotic, and stimulant laxatives mostly. The disaccharides and added alditols are basically osmotic laxatives, and they are used such as lactulose and sorbitols. Paraffinols and emollient laxatives are also can improve basically with enemas. Stimulant laxatives can be also used, such as diphenyl, such as bicosadil and bisacodyl, and sodium picosulfate. And also senna and all of them, they are known as stimulant laxatives. And they each have their form. The bulk forming are the most common, such as isopgulapusi and also mycelium and polyethylene glycols, such as macrogol. It usually does intraluminal water binding and the bulk forming, and it decreases stool consistency basically. However, this is not indicated in a patient with an opioid-induced constipation. For opioid-induced constipation, you should always use osmotic laxatives and stimulant laxatives also. But first line is usually always bulk forming, and with it might be required an osmotic. And if those fails, then you can also give them stimulant laxative as a second line. Now, along with the laxatives, and most patients will improve with this alone, but we also need to give them a diary, and we ask them to keep a score about keep a diary regarding how many times do they have constipation and what is the impact on their life, and how many times they have to digitate, put pressure, or what was the problem with it. And this also allows the patient to mindfully use this. Now, if all of those drugs fail, you have to, if for an example, there is the other drug known as prucalopride. Now, prucalopride targets 5-HT4 receptors, and they increase the motility. And there are randomized trials which has shown to improve its efficacy. And it can be only used as per the NICE guideline when you have used 2 laxatives on its maximum dose for 6 months. Only then you can trial prucalopride for 4 weeks and to see its effect. And it triggers a peristaltic reflex and a colonic mass movement. Biofeedback, this is another important thing, especially in patients with ODS and slow transit constipation, where the patient's brain is retrained how to open their bowels. And rectal irrigation techniques Also, enemas and suppositories, they are also required to help patient open their bowels. And this is the first line of management for every single patient, for whatever the cause it is, to do management of the constipations, basically. Now, when these all fail, we can move to surgery. And surgery itself is, there are various forms. So usually these patients, they should be referred to the pelvic floor MDT. And from the pelvic floor MDT, they will offer various options. And for various problems, there are various treatments. So it is quite difficult. Usually in the exam, it is that we would suggest the patient, I would take this patient to the pelvic floor MDT, and most likely this patient can be either have this or that, depending on after the discussions. So at least you need to know the discussion points, basically, or the procedures that they might offer in pelvic floor MDT. So if the patient has rectocele, then you can send the patient with a gynae or colorectal surgeons for posterior colporrhaphy only. And if it's only with a rectocele, isolated rectocele. If the patient has rectocele along with intussusception, then you need to reinforce their anterior anorectal junctional wall. And then those patients may require STAR procedure, which is the staple transanal rectal resection. Now, it is not that common. I mean, it is still practiced, but it has fallen a bit of the favor. It is fallen a bit in the favor of it. So that's something needs to be kept in mind. Rectopexy, with or without mesh, if the patient has a rectal prolapse, that is also something that we need, another option. Sacral neuromodulation has been reported to improve rectal sensitivity to balloon distension in patients with chronic constipation and rectal hyposensitivity. Although sacral neuromodulation, if you remember, it's the first line in fecal incontinence, but in constipation also, they can also be used. ACE procedures are used to achieve by giving antegrade colonic irrigation through either a tube cecostomy or an appendicectomy. And there has been good clinical outcomes reported in children, especially who have spinal problems, but in adults, the results are not that great. So it is commonly used for children with spinal or in patients with spinal problems, but not very commonly in all types of slow transit constipation. And last of all, of course, operation and ileostomy or even colectomy. Now, colectomy should only be offered for patients who has complete refractory constipation syndrome with a proven generalized low colonic transit. And usually, even in these cases, we advise to do an ileostomy first and to see whether patient symptoms are improved, and then, if possible, to do a colectomy. But colectomy is never the first choice of treatment for patients with chronic constipation, and that should be kept in mind. And also, you cannot do colectomies or ileostomies in patient who has pan-GI motility. Like if the patient has gastric dysmotility, we cannot offer these patients for a colectomy. So those are contraindications of doing a colectomy for those patients. So that also needs to be kept in mind. Now, the outcomes. What are the outcomes of chronic constipation? So conservative treatments actually show improvement in 30% of people. So 1/3 of the people will actually improve with just those lifestyle modification. And, they can be required indefinitely. And also you have to have a realistic conversation with the patient. If a patient normally only open bowel 3 times a day or 3 times a week, then, they might not go to opening their bowels every day, but perhaps every alternative day. And the laxatives and enemas basically can be used indefinitely, but they have to be titrated according to the patient's need and the patient's lifestyle. But they can offer real relief. Biofeedback and psychotherapy requires time and commitment to yield result, but actually they can offer the lasting improvements, which is why they are the first line of management as per NICE guideline in chronic constipations. And even after operation, even if those patients do go for operation, they still need biofeedback. And actually, biofeedback has shown to improve results when they are combined after and before surgery. So that is also something we have to tell the patients. Surgery actually has uneven results, and it seems to be most successful when combined with other treatments. But there is no one size fits all, and there is a quite debate or variation of opinion in terms of what is the best procedure for patients. So so in the exam, it's better to not to say, I would say just not to have just one procedure, but give options that these can be done, but of course suitable. For an example, for rectocele patients, you can give them colporaphy. If the patient has intersusception and rectocele, then you can do star procedures. But keep in mind, some examiners might be against some procedures. There are a lot of controversies now regarding ventral mesh rectopexy, so that is something also needs to be kept in mind, because if you get these kind of patients in the long cases, then you might be asked to consent the patients and also mention the mesh complications. So, in summary, chronic constipation, clinical examination and investigation to exclude other causes. Management is always conservative agents first. If it's success, we continue. If it's failure, then we need to do further investigations. If it is obstructed defecation, then if they're functional, if there is no mechanical obstruction, then we cannot offer them surgery. So they need biofeedback therapy and rectal irrigation. If they're mechanical, then you can give a variety of procedures such as star, lap, ventral rectopexy, and rectocele. Slow transit constipation, they can be conservative, sacral nerve modulation, prucalopride, and can be also done by subtotal colectomy and ileorectal anastomosis. And in mixed patients, patients who has a bit of ODS along with the slow transit constipation, it is those patients are the tricky ones, and they need to be always run through and pelvic floor MDT. Remember, these proctology is a quality of life improving operation. So it is very important to manage patient's expectation and also have the patient on board, because the patient and you have to be a team in order to give the best result to achieve for the patient. I hope you find this episode useful. The podcast, in the podcast of the Studying for FRCS, there are more detail of the slow transit constipations and of the various functional bowel disorders. So do listen to them if you want further clarification. This has been a short summary just to give an idea about how to approach these patients in examinations and what to ask and what points to give in mind. So if you have any comments, please comment, and please also subscribe for the channel, and please leave any helpful comments or in terms of what topic would you want to see discussed about basically. I hope you have a lovely day. Goodbye.